So it is an honor and privilege to introduce the two fellows who will be presenting today. So Jacques will go first. Jacques joined us after completing his medical education in Ecuador and has done a tremendous job on site. He has worked at this point, correct me if I'm wrong, Jacques, at all four main sites: Elmhurst, Morningside, West, and East. All of you who know him on a personal level, I'm sure appreciate the work that he has done for our department, and we're very excited to hear his stuff. All right, Jacques, go ahead.
Thank you. Do you hear me well? Do you hear me?
Yes.
Thank you for the introduction. Thank you for the opportunity to present today. Let me share my screen. Everybody see the screen? Everybody see it, right?
Yes, go ahead.
Okay, so thank you for the opportunity to present part of the research that I've been doing here at Mount Sinai. I'm going to talk specifically about our topic. I'm really interested. It's in-hospital stroke now in the endovascular era. I do not have any kind of a disclosure to mention at this point. So why I choose this topic, as Dr. Panov mentioned, the pre-residency fellows and junior residents who take call, we are in constant awareness of how busy our cerebrovascular service is. I'm pretty sure it's one of the busiest services in the city. You know, seeing the triaging process, start with the workup remotely from other satellite hospitals. But I'm I was curious about how we're doing, or how is the inpatient population doing in the setting of the strokes. That's why I look for the data that we have available. So as a definition, what is an in-hospital stroke? This is a new onset stroke in patients who are already hospitalized for any other different reason. The incidence of this condition is between 2 and 17% of the overall strokes. What would be the expectation in the cases where a patient suffers stroke while hospitalized? The expectation will be that this patient may benefit from the highly monitored environment that the hospital provides, and also the theoretical faster access to workup and treatment. But previous research demonstrates that this is not the case. Previous research demonstrates that there were delays in the recognition of symptoms, lack of knowledge about specific protocols in order to assess or start working up of strokes, delays in obtaining radiological studies, as well as adequate treatment institution. So we looked the data that we have in the stroke database for those patients from November 2014 to August 2019 who had a stroke and underwent endovascular treatment. We divide these patients in 3 categories. Outside hospital stroke, as a definition, we said that this population is patients who had a stroke and arrived to a thrombectomy capable stroke center. The transfer cohort is those patients who with stroke symptoms who arrive to a non-thrombectomy capable center or primary stroke center, which provide initial assessment, initial workup, and also medical treatment, which include administration of TPA. And the in-hospital stroke that I already mentioned was the definition. Among the variables, I included general demographics, comorbidities, admission in IHSS, and pre-morbid modified Ramkin score. Logistical variables, we look for the time and date of the first symptom discovered, time and date of a stroke code, and image obtained. The aspect score was also recorded in before the intervention. And regarding the interventional variables, we include ticket score, number of passes, timing between discovery of symptoms to stroke code, discovery of symptoms to to imaging obtained and discovery of symptoms to final recanalization. And the outcome variables will include the discharge NIHS and discharge modified Rankin scale. In the in-hospital score, we also look for the admission diagnosis other than arteriovascular. We exclude all patients with underlying neurosurgical, neurological disease that could bias the overall results. And also, if these patients that were admitted require any kind of intervention, we mention it. Also, we look the physical location of the patient at the moment of the stroke. As a result, we found that our cohort includes 526 patients. From these, 38% were outside hospital, 50% was transferred, and around 11% of the patients were in hospital strokes. We didn't find any kind of a difference regarding the age or the sex, neither admission NIHS or discharge NIHS. Interestingly, we found that the in-hospital stroke have acceptable good MRS, pre-admission MRS in 82% of the cases, compared with the 79% of the outside hospital and 83% of the transfers. Also, the discharge modified Rankin scale did not show any significant difference, but a tendency to present with lower good outcome in the in-hospital setting compared with the outside hospital and transfer was noticed. Interestingly, we found that the transfer cohort had worse aspect score compared with the inpatient population, and this was significant after analysis. There is no difference in the number of passes, and also the tendency of the in-hospital cohort to have less frequent good TK outcome after intervention compared with the outside hospital was the tendency was to be 86% good outcome compared with the 94% in outside and transfers. When we observe the in-hospital patients, we noticed that in-hospital patients were significantly sicker compared with the outside and transfer. We noticed that 41% of the in-hospital has a previous history of coronary artery disease, around 20% coronary artery bypass graft in the past, 30% with congestive heart failure, and 21% with chronic kidney disease. And this was significantly different compared with the other two cohorts. We found that most of the patients, 60% of the in-hospital cohort, were admitted due to a cardiovascular condition, followed by a pulmonary condition, oncological in 5%, and diverse and different kind of admission diagnosis in 22%, which includes psychiatric conditions, trauma, orthopedic, GI, and OB diseases. 63% of these patients had a stroke while they were in the regular ward, in the regular floor, other than the neurology or neurosurgery, and also 21% had a stroke in the critical care units that are not neurocritical care. Regarding the timing, we found that symptoms discovered to stroke code was significantly faster in the inpatient population compared with the outside hospital and transfer. The symptoms discovered to CTA, the difference was not different between of them, and the outside hospital had a faster workup for CTA. And the symptoms discovered to final recanalization, we noticed that the inpatient population was significantly faster compared with the transfer, but also faster compared with the outside hospital, but this was not significant. As a discussion, we found that our population, the inpatient population, was had a worse general health status and comorbidities compared with the other populations. Interestingly, a pretty good admission functional outcome, functional status was observed in 82% of this population. 60% of the patient has a cardiovascular disease, underlying cardiovascular disease at the moment of a stroke. most of the patients were diagnosed in the regular hospital ward and also in the intensive care unit other than a neurosurgical related. The question at this point is like how different or how, if there's any difference between services, between areas in the hospital regarding the frequency of neurochecks or quality of training or quality of recognition of stroke symptoms, if there's any difference between services. We found that the inpatient stroke were recognized 37 minutes significantly faster compared with the outside hospital and 132 minutes compared with the transfer. This discovery to symptoms to recanalization was significantly faster in the in-hospital population compared with the transfer, and also to the outside hospital, but this was not significant. As I mentioned before, the good functional outcome was observed more frequently in the outpatient and transfer population, but this difference was not significant compared with the inpatient population, which can be translated that this population also may benefit for a timely onset of endovascular treatment. As we know, every single day we have new data of how the endovascular treatment has become the standard of care for acute stroke. And we, as a Mount Sinai, I think we have a significant high volume of cases, which we can. And the thing is, we need to assess how we're doing in the in-hospital setting. And a very important thing that I want to stress the fact is that this could not be possible if it's not a team player, if it's not a team involvement of different services, which include the neurology service, radiology, INR, stroke service, as well as all the technicians and anesthesiologists and neurosurgery at the moment of a stroke code. This is a quick workflow of stroke code in hospital, while in hospital, that one of the collaborators with this project, neurology resident, provide in order to see how we deal with the in-hospital stroke. And a summary point, we know that the hospitalized patient has more pro-atherosclerotic factors that increase the risk of stroke compared with the outpatient population. That cardiovascular conditions are the more frequent admission diagnosis for patients with in-hospital strokes. We also demonstrate that, contrary to the previously report, that in-hospital strokes are recognized faster compared with the previous report research. And also the similar benefits from the endovascular treatment with good rate of recanalization and similar functional outcomes was achieved in this population. Thank you, and I want to express my gratitude with the team, with all the faculties that has allowed me to be part of the team and taking care of your patients. And I hope to continue to contribute with the department in the future. Thank you.
Thank you, Jacques. Just wanted to check if there are any questions, if anything has shown up for you, Peter or Chris. Okay, we can leave those for the endo as they come up.
Can I ask one question? Jacques, do you have timing data, time to procedure for patients who underwent thrombectomy for inpatients versus transferred patients? Maybe also versus ER access, direct access to ER patients?
Yeah, that data, this project is still under review. This is a preliminary data. The thing is, the red color has been updated, so we need to go back, because I'm pretty sure that data, specifically the one that you're asking, it's available, so we can enhance the project before submission when we have that kind of data.
I've seen in some studies, it seems counterintuitive, but sometimes the patients coming in can get to the room faster than patients discovered in the hospital because you've got that pathway set, and each step is very clear.
Yeah, I think that was it has been described that for example, a patient came to the ED, everybody's aware of what the stroke is, or how to deal with the workflow that blocking the CAT scan, having the neurology resident bringing the patient to a CAT scan, and they notifying the INR team, so everybody's aware. And that's what we think, that the outside hospital who arrive to the ED could have a faster kind of workup in general compared with the in-house.
Jacques, your findings are really surprising as compared to what's been reported in literature. Do you think that your findings are going to be applicable to other centers outside of Mount Sinai, or is this a product of how well we've got our processes in place for acute stroke?
I think it would be great if we can have a collaboration with other comprehensive stroke centers, because that can provide that overall and over time, after getting a certification to be a comprehensive stroke center, this can be improved, timing can be improved. The data that I'm showing here is pretty much only among Mount Sinai Health System, includes all the satellite hospital, and I think there's room for improvement after this, but so far I think our workflow is working properly.
Yeah, and Neha, this is Joanna. It's an idea. These patients are all inpatients in a thrombectomy stroke center already. So if we wanted to look at that, we could look at the transfer patients and break them down into those transferred from an inpatient status, and we could try to see if the same holds true for inpatients in primary stroke centers. I don't know that we have all of the data, but that's a potential addition to the project.
Yeah, that also will be included in the final document.
Thank you, Jacques, for that. So again, you and all of our fellows testify to the fact that international neurosurgery is an incredible, strong arena, and we at Sinai are lucky to be involved in your training.